Well, it's your style, whatever you do, right? The most important is you know what is semi-recumbent. So we'll put new words into your brain again to make a new file. All right, so that when you are in your NCLEX exam, you're ready. So anyway, good morning. So we'll be here again until 4 o'clock. So if you have any questions, raise your hands, participate. Nothing to worry, to be shy about. Okay, so we are here to learn. So I will give your access online later today. All right. So and during our break, maybe I will put in, or if you have your USB or your computer, so I can just put in your questionnaires in your computers. Okay. So you have your access to the videos that we discussed yesterday and today. That will be starting tomorrow, right? So Monday all the way to Friday, you can always watch the videos that we discussed. So it's not hard for you. You don't need to record anything because you have an access to it. Okay? And that's a video. So whenever you are driving, you can still listen to
George,
the... Huh?
do you have
Sorry.
the state phone?
Yes, in my bag. I know
Thank you.
because my boss is calling me. Anyway, so yeah, so when you're driving, you can use your phone. Just listen to the audio, of course. You will not be watching while driving, I think. Right? So some people I do watch when I'm driving. I don't know, maybe it depends on the way how you really handle driving. Can you handle driving while texting? We do that in the Philippines, right? We do that here too, but it's dangerous, I know. But yeah, you can listen to the audio while using your computer. So in your computer, you can just access our website, and then log in. Then you can listen or watch your videos while driving. That's fine, right? So going to work, maybe you can listen a little bit of it. So that's good. All right. So yesterday we have a lot of discussions already, and we were discussing those questions, some strategies, but our main focus really for passing the NCLEX exam is not really using our strategy, but using our knowledge about the topics, right? So we know that there will be airway breathing circulations that we discuss, but if you don't know about auto-saturations, about partial oxygenation, about equipments that they use, about room air, some people or some students doesn't understand what is room air, right? So some of them, they thought that room air is really bad, but this is room air. We are breathing in a room air and we are stable, okay? But when you're using all those masks, all those nasal cannula, then that changes your conditions from better to worse. And our priority are the worst condition of our patient. So, but we need to understand the normal versus the abnormal. We talked about our patient also yesterday about the level of auto-saturation. So don't forget, we have acute respiratory disorders and COPD. We identified our COPD. There are 4 COPD. So the rest of the respiratory could be an acute respiratory attack, right? Same thing with our MMM, TVSS in our airborne. So we identify our airborne. So that means we don't need to think of any other airborne. The only thing that might be including will be our COVID-19, but we are not so sure yet as of now, right? But the most important now for COVID-19, we have our facial covering. Our nurses in the hospital are using N95, all right? So that means there is really something about it that we don't really know yet because they take out all the information to the CDC. But still, it's not popping up in the NCLEX exam, but I think if there will be, it will be what type of equipment you'll be using. When you are in the hospital setting, you know what the equipment would that be, and that will be N95, right? Otherwise, you have to use gloves and gown because they also thought that it might be from contact contaminated equipment or contaminating the patients. Touching one patient to another could facilitate transmission of the infection like COVID, right? So don't forget, contact isolations is when you touch a patient and when you touch another patient, that's the only time you transmit, then that patient is considered contact infection, not your sexual contact. So remember, all your STDs doesn't belong to any contact isolation, but they only belong to standard isolation. So always remember that the isolations But we'll discuss that more in our fundamentals as we start today. Okay? So you have this equipment that we discussed, and you are very sure about this already, hopefully, right? So I'm hoping that you are very much familiar with this already. So I will just give a copy to these two guys. All right, so you know your normals and you know your abnormals, which is very important for this topic. All right, because if you don't know the normals, then therefore it's hard to understand the abnormals as well. You remember this discussion yesterday, right? So make sure there's a lot of questions about this, but I want you to understand that this is a drainage system. So how do you drain the fluid or the air? Remember the insertion of the tube from upper, air from lower is water. And you need to put it down because it should drain. So you don't put it on top of the patient's bed because what's the purpose of draining? It's not draining. And remember, there's a clamp. You need to unclamp because if you clamp it, how will it drain? Okay, so know all your chambers because the chambers are the ones that you have to understand very carefully. So otherwise, we have medications, but we'll discuss that. We know how to prioritize our patients also, and we have that in our video. So Victor, you can go back to the video and watch it, okay? So we discussed a little bit of maternity. We understand what is acceleration versus deceleration, but we also understand that deceleration is lack of oxygenation. And once there is deceleration, it's really hard. But you need to understand which deceleration is more important among the deceleration. That will be your letter V, right? That will be your variable deceleration. That means there's total off or closure of the oxygen supply. Okay? So that's why we highlight that it's cord compression. So when the placenta is off on the wall, that means total loss of oxygen. It could also lead into variable deceleration. So don't just think that it is only cord compression. What if there is no cord compression in your chest? But there was, the placenta is totally off on the wall of the uterus. Then it's the same thing. There is no oxygen supply anymore. That leads to that complication right here. Okay? Because variable deceleration means no oxygen, total loss of oxygen. Because when you say cord compression, we close it, right? So that's why what's the position of the mom in case if it's cord compression, then it should be Trendelenburg to the left side, right? So then we remove that obstruction. Whether it is vena cava syndrome, still the same. But the only thing is to position every patient to increase oxygenation, whatever it would be, it will always be left, no right side position. All right? Oxygenation is positioned to the left side. For example, pulmonary embolism, lack of oxygenation, left side, right? If there is no semi-Fowlers, do not answer semi-recumbent, all right? It should be orthopnic position or left side. Because everything is about left side, it will increase the oxygenation to your patient. Because if you apply the right side, you are going to compress the vena cava, less return of unoxygenated blood to the lungs, then there will be no oxygenated blood to supply. Because we cut off the supply of non-oxygenated blood. All right? So, again, we discussed about magnesium sulfate therapy, all right? So whether it's magnesium or calcium, it will always causes weakness to you when these things goes up, right? Because they are relaxant electrolytes. But the thing is, magnesium and calcium, they're opposite direction. So when magnesium goes up, calcium is the antidote, all right? But if you want to talk about what is the problem in magnesium, it's the same problem in calcium. Okay? When I have no calcium, I have seizures and tetany. What about if I have no magnesium? The same thing. Because when these electrolytes goes down, you become hyperactive. Okay? Hyperactive means seizures, hypertension, restlessness. Okay? So there's a lot of meaning of hyperactivity in our patient. So I have one student that was telling me about Addison's disease yesterday that we talked about. Everything is low except potassium and calcium. And she was telling me restlessness is one of the problem to our slow activity. Remember, when you're restlessness means restless. You are not resting. You are restless. Is that hyperactivity or hypoactivity? Hyper, right? Because you are restless. You're not resting. All right? It doesn't mean rest and the less. No more. The rest is no more, not there anymore. Okay? So I know there are so many terms that we might really have to analyze it, what is really the simple meaning to it. Okay? So we discuss our pacemaker, and hopefully we will highlight that in our ECG. We will highlight that. So the answers in your quiz is in the online video, Victor. All right, so we discussed about that yesterday. And those questions are coming from our test plan. Okay, so the test plan is where we are being guided on what to study before taking the test. So let's go to our ECG. Okay. All right. So ECG in your NCLEX exam, there's a lot of this, but these are pictures in your NCLEX exam. So are you familiar with the pictures in your ECG? So when you talk of ECG, there are two things to remember. One is tachycardia. If you remember, what is tachycardia? All right. One is tachycardia, and the other one is bradycardia. So you have to understand what's the other meaning of tachycardia, because what if tachycardia is not there? NCLEX-RN exam is harder than the NCLEX-LVN exam. In LVN, they will use tachycardia, right? In RN, maybe they're using dysrhythmia, arrhythmia, ectopic beats, but they will use chest pain in every tachycardia. Okay, so that's why NCLEX is a game of rewarding. If you don't know what's the term, semi-recumbent, good luck, right? Dorsal recumbent, good luck, because I don't remember about it, okay? So the other terms for tachycardia will be palpitation. So the patient will be saying, I'm having palpitation. It might be, the patient may be anxious, but whether it's anxiety-related tachycardia, it's still tachycardia. Tachycardia is palpitation. Anyone who is running, anyone who is excited is having palpitation. But remember, that palpitation can cause decreased cardiac output. Remember our discussion on digoxin and Lasix in connection to your patient with CHF. CHF is tachycardia. That's why they always have a chest pain. And the problem is, once your heart is pumping so fast, it cannot acquire oxygen to the muscles of the heart. So when your heart is not receiving blood into the muscles of the heart, it will release lactic acid, causing chest pain, right? Because the problem is, the more it is faster, our oxygen supply to the muscles cannot receive blood from the artery because it's fast beat and it cannot go there, right? That's why we are going to slow it down, more oxygen to the muscle, no lactic acid release, and the pump is stronger. Then there will be increased cardiac output. That's our goal. Remember, all heart medication, your goal is to increase the cardiac output. All right? Our cardiac output is 5 liters per minute. And how do you know that it is effective? Urine output. All right? I'm taking my digoxin, and then your answer is, oh, the heart rate is slowing down. That's a wrong answer. All right? Unless there is no other answer as urine output, then your next answer will be looking on normal heart rhythm. But still, even if there is a normal heart rhythm and there is no increased urine output, that means there's a retention of fluid. All right? That means it's not effective. That's why you need to weigh your patient's CHF every single day in the morning using one weighing scale machine, right, or equipment, because you want to make sure that scale equipment will be the same result from every single day. All right. And if your patient is CHF or renal failure, make sure you really have to ask the patient how much water, how much urine output, your CNA, how much urine output has been discarded. Why? Because if you put 1,200 in all your renal failure, the doctor will tell you, oh my God, Kim, you are a miracle, right? Because all renal failure has 1,200 ml of urine output every day. And then every other nurse is only 300 output. then you make all your patients normal, right? So do not make a drawing out of your assessment because that reflects who you are in the hospital, right? You're assessing a patient, you are too tired, you put IV on the right hand, but the IV is already on the left hand. Okay, so when you're doing assessment, you go there, ask the patient, you look at it where it is. If the patient's polycatheter, then you have to look at it. If there's none, then that's your assessment. If some other nurses are just copying from yesterday's assessment because they want to be in a hurry and they forgot to erase, sorry. Remember, when you're done it in EHR, electronic health records, you cannot erase it anymore. Once you submitted it, that's it. Okay? So that's why you really have to understand it very carefully. So palpitation, dysrhythmia, arrhythmia, ectopic beats, or chest pain are all tachycardia manifestations in your patient. Okay? So why there is chest pain? Because the heart cannot receive muscle, the heart of the muscle cannot receive oxygenated blood anymore because the heart is beating so fast. All right? And because of the lactic acid that is being released. So imagine if I am exercising now, I'm using a dumbbell because there's no gym and I'm having a lot of muscles on my abdomen, right? So when you have to lift, you do like this, you compress. What happened to your arteries? Constricted or dilated? Constricted, right? So the faster I'm going to do like that and the heavier it will be, it will constrict all my arteries. And what will happen for me 1 or 2 days after? Pain. Because there was less oxygen into my muscles. Though in the muscles of our hands in our body, it could help to grow the muscle, but not in your heart. It will kill you, right? It will cause MI, myocardial infarction. So what is the infarction? The muscles of the heart are damaged. That's infarction. That's why it's painful. So when there's infarction, can you remove that? Can you debride that infarction in your heart? You cannot, right? Because otherwise you're gonna die because your heart is being removed from other part of it. So it's not possible. So otherwise, tachycardia is narrowed heartbeat. Okay? So tachycardia is narrowed. It's fast and they are near to each other. So if you make a drawing out of it, it's gonna be like this, right? So they are like that. So they're narrow. Depends on what kind of rhythm we are looking. Okay? It's a normal rhythm, but it's just too near to each other, and that's why you're gonna be remembering and taking your NCLEX because it's just a strip of a picture. Okay? So now if you're looking on the problems that we have our atrial and ventricular. So our heart is divided into 2 parts. Okay? So our heart is divided into 2 parts. We have the atrial and the ventricular. So where is your atrial? On the upper portion. So atrial, ventricular. Okay? So ventricular is divided, our heart is divided also into 2 parts, the right and the left. Okay? So, and then we have, how many valves do we have in our heart?
4.
4. All right? So we have tricuspid. What else? Mitral. So we have aorta, aortic valve, and mitral valve. We have tricuspid and pulmonary valve right here. Okay? So you have PPAM, PPAM in your, what we call this, the valve. So how important is that to learn? But of course, always remember, the biggest role in pumping the blood back to the circulation is in the ventricle. All right? So therefore, if I have a problem that says atrial tachycardia versus ventricular tachycardia, which one is a priority patient? Knowing your concept here, the biggest role in the heart muscle is the ventricular. Which one is your priority patient? Ventricular problem. All right? So don't choose atrial problem because there is always a priority for having a ventricular problem patient. Okay? Though you understand also over here that there are several problems on the atrial and there's also ventricular problems. There's several ventricular problems. One of the best problem in ventricular is asystole or asystole, which is the straight line. And I wish all your pictures in your NCLEX exam is a straight line, right? So what do you do when you found out there's a straight line? Are you gonna check the patient, or are you gonna activate code blue? Which one is your priority? Check the patient or code blue? Check the patient first, because maybe the patient removed the Holter monitor. We are not sure yet, right? So what if we have a straight line and we have a ventricular fibrillation, AFib, versus asystole? Which patient is your priority? The asystole or the AFib? Asystole, right? So why? Remember, I want you to understand, all patients monitored for the heart rhythms are full code patients. Whether that patient is a straight line, that's your priority, because you need to revive that patient, because that patient is a full code. All right? We don't put DNR patient in telemetry. Okay? So any of your patients in the NCLEX exam in hospital-based questions are all full code. They are not DNR. So that will become your priority when you see a straight line. Because you need to find out. The rest of them still have a heart rate. The other one is no heart rate. You don't declare them that they're dead already and there's no use for them to be revived. But they are full code, right? So I don't know if there is a DNR patient that's a Holter monitor. What for? Isn't it? Okay, so understanding your atrial. We have 3 problems in your atrial, but I want you to know that when it is atrial, look at the rhythms that we have. All right. So, so our rhythms for our atrial is gonna be like this. So we have atrial. All right. So it represents letter A. That's how simple that would be to look at. So where is the problem in your atrial? The problem that you have to look for in your atrial is in between the letter A's, right there, all right? That's where you look for the problem, right at the middle of every letter A. Okay, so you see that one? Oh, that's letter A, that's atrial. So what's next to remember? Oh, is that atrial fib? Is that atrial flutter? Or is that atrial tachycardia? Okay, so you look at your atrial fibrillation. What does it mean? What's the meaning of fibrillation? Irregular. So if you don't understand fibrillation, then you don't understand the picture. All right, and you might not get the right answer. So if you understand what is atrial fib, whether I go to ventricular fib, they're both irregular rhythm. Okay, so they're like chaotic rhythms. Why is it like that? So it's letter A, but in the middle of it, it's totally different. Okay, so then therefore it's irregular, or we call that fibrillation. What about a flutter? The atrial flutter is a sawtooth pattern. So in between the letter A, the patterns in between is like a sawtooth or a shark's tooth. So I'm sure you're familiar what is a sawtooth or what is a shark's tooth, unless you have not watched those movies, or a saw, right? So it's like, how come it's like that? It's like a tooth of a shark or a sawtooth. Okay, so that's how. But we'll see all the pictures. Then what about atrial tachycardia? It's normal rhythm, but it is narrowed. All right. The letter A's and the pattern in betweens are normal, but they are so near to each other. That is the difference from all those AFib, A flutter, and A tachycardia. But among the atrial problem, which one is the priority patient? The atrial fibrillation. Why atrial fibrillation becomes a priority? Only among, okay, so all the ECGs in your atrial and ventricular, there's only one pattern that has clot forming ECG result, and that's only your atrial fib. All right. Atrial fib is the only one with clot, potential for clot or will cause clot. So that's why you look at the lower portion, heparin, Xarelto, Pradaxa, all right? I will give you this one, sorry. Here is a simplified understanding of the. Okay, so go back to your atrial. There's only, between atrial or ventricular, there's only one ECG that has potential or will form clot. And that will be your atrial fib. That's why whenever you see atrial fibrillation patient, what is your priority? And you're looking on, do I have to perform defibrillation? Do I have to perform cardioversion? But maybe there's heparin, that will be your best answer. All right? Is your priority, this patient should not create clot. Okay? So, well, if you're looking on your ventricular problem, there's 4 of them. One will be ventricular fib, and you know what is the meaning of fibrillation already, irregular. So if you're looking on ventricular, the rhythms of your ventricular, as we say, it looks like this, right? So that's letter V, letter ventricular. So they are forming like this. So it's easier to remember your ventricular because they are forming letter V, okay? So you will also see what is irregular, because irregular, it's going to be letter like this, but it did like that. How come? Then it becomes irregular because they are supposed to be almost letter V of each lines. So that's the difference between the drawing. So looking back on your ventricular, deep fib or ventricular fibrillation is an irregular. Fibrillation is irregular. You see that rhythm. Ventricular tachycardia is a normal ventricular rhythm, but it is narrow. They're near to each other. Okay? And then asystole, my God, I don't need to draw an asystole. It's a straight line. That's going to be simple for you, right? So, but remember, that's your priority among the ECG. All right? And then the last one is your premature ventricular contractions, or PVC. The PVC is premature ventricular contractions. So what is the meaning of premature ventricular contractions? You have normal rhythm, and then in between the normal rhythm, there is like a premature rhythm. All right, you can see that premature rhythm. It can be bigymy, trigymy, or quadrymy. Oh my God, so many gymy, right? So what does that mean? When you see bigymy, one normal followed by one abnormal equals 2. But we'll see a drawing, okay? So just to understand that in words, when you see bigymy, one normal plus one abnormal equals bigymy. What about trigymy? Okay, so it can be 2 normals and 1 abnormal. It could be trigymy. And then quadrymy is for 2 normals, 2 abnormals equals quadrymy. But I'll show you a picture later on. So what does that mean? What is the cause of premature ventricular contraction? There's only 2 reasons for that. One is low oxygenation, and one is low in potassium level. So if you are in your NCLEX exam, you don't need to analyze anything or anymore. You're just looking for what's the cause of this. So I know low potassium, well, it's not low potassium. Oh, it's low in oxygen, so that's it, right? So, but you have to note that how high or how many PVCs you will notice to make it dangerous for the patient. All right. When the PVCs is 6 and below or below 6, when you count it, how many abnormals in between the normal rhythm, then there will be less than 6 or 6 below, then that is okay. But when it is 7 and above, that is going to cause cardiac arrest in your patient. That's why when there is low potassium, there is PVC. Or when there is low oxygenation, there is PVC. So what will be the next manifestation? Chest pain. If we are not going to manage the chest pain of our patient, what's next to happen in a low potassium patient? Cardiac arrest. Right? But since the patient is doing a cardiac arrest, since they are full code, then what we are going to do is we have to perform CPR. Then we activate, we assess the patient, we activate the code blue, we CPR, we have our activation of our ACLS, our doctors and nurses are there to give medications, right? So, all right. So the other one is, okay, so the next one will be your medication. So what will be your drug of choice? I want you to understand that all these medications listed here are all medications that can be used for both atrial and ventricular. Okay, but remember, there's always a drug of choice. When you see drug of choice, when there is atrial, amiodarone is the first medication to administer. All right? When there is atrial problem, you have to use amiodarone. So whether they put beta blocker, calcium channel blocker, erythritol, but there is amiodarone, I will choose amiodarone because all of these medications are applicable anyway. All right? If it is ventricular problem, the drug of choice will be lidocaine. So whatever medication is presented in the NCLEX exam with all this medication listed about below here, including digoxin, your best drug of choice will be lidocaine for ventricular problems. So what if there is no amiodarone and there is no lidocaine? Well, you have to choose from the other list. You have the beta blocker, calcium channel blockers, you have erythritol, you have procainamide, and you have your digoxin. All right, that's why when you give beta blocker, you have to check blood pressure and pulse rate. The same thing with your calcium channel blocker. There are two parameters. So that's why when you are having anxiety, doctor will choose calcium channel blockers to be given to you because it rests your heart and it will make your blood pressure go down and you go home. We don't give you Ativan in ER when you have anxiety problem. Why? So you can drive and go home. We don't want you to stay in ER. All right? Because once we give you Ativan in ER, what's next? You have to stay for at least 24 to 48 hours because you are dangerous for driving going back home. All right? So remember, hyperactivity, when you give a medication such as relaxant, such as anti-blood pressure medication, you're going to relax. Okay? So those medications can be applied to many reasons. So sometimes we think, how come my doctor prescribed me this medication? I don't have I don't have blood pressure issue, but you have hyperactivity issue. Okay? So understand that will be amiodarone if there is amiodarone as a drug of choice and lidocaine as a drug of choice. So for your PVC, lidocaine will be your drug of choice all the time. Okay? But of course, asystole, what's the drug of choice for asystole? Epinephrine. Okay, so when there is a flat line, you have to use epinephrine. That's always the answer in your NCLEX exam. So whenever there is AFib, that means there is a clot potential for that patient. All right? So when we have an AFib, we have to prepare. Think about first before giving amiodarone. Maybe I have to give heparin first before I will give amiodarone. You know? Because once I prevent the clot, my patient will not develop pulmonary embolism because they might die because of the PE, but not because of the tachycardia. Okay? So heparin, Xarelto, and Pradaxa. So what's the difference between, well, Coumadin can be a part of it, but remember, all anticoagulant can treat clot formation. They will prevent clot formation. But the only reason why we don't usually give Coumadin to patients with atrial problem or heart problem like atrial fib, it's because we need to monitor levels of blood in our patients for Coumadin. So that's why we always given a maintenance dose for Pradaxa or Xarelto. You have that there in your list. Pradaxa or Xarelto. You got it? All right. So if you go to your other options of defibrillation versus cardioversion and AICD. So this part right here. Okay. So if you have
and Xarelto.
It might be Xarelto that apply. Why not? There's always a possibility. All right. That's why you need to learn all the medications that are commonly given to your patients.
But if they're all four, which one will be?
They're all anticoagulants. But if you wanna ask me which one will help prevent clot formation right away, heparin. All right.
So heparin would be priority.
Heparin will be priority. So if you look at here in your defib and cardioversion, this part, okay, the only procedure to be done to a patient who is conscious, especially AFib, all right? AFib is conscious to be going for a procedure for shock, all right, to correct the heart, the tachycardia.
but they're alert and oriented. So what are we going to do? We have to make sure that they have a consent, but when you perform a shock to a patient with AFib, they will form a clot. So your priority is inject heparin. Do not miss out the heparin prior to cardioversion. All right? So there are only two patients that will be undergoing cardioversion, AFib and ventricular tachycardia. So what is the purpose of cardioversion? It's similar to defib, but defibrillation is used only to unconscious patient. All right, that's two different procedure. If you are unconscious, I will electrocute you by using defibrillator. Okay, but if you are conscious and we are going to correct the rhythm of your heart, we will perform cardioversion. But we need consent to the conscious patient. Do you think you're gonna like being electrocuted while you're awake, alert, and oriented? Right? So they have to sign a consent and they will put to sleep, and then it is going to create that shock. But the problem is among the ECG, the only one that creates the clot is the AFib. That's why you have to think first before doing anything. Heparin should be administered to your patient with AFib before the rest of other procedures or medication. All right. So, but select all that apply. Yes, there are all medications to all of this, but the only one that will be prevented from clot is there is only one, and that will be AFib. Okay, I'm sure you will encounter that in your practice test or even in your NCLEX exam. Okay, so what else do we have? Defibrillation is only for unconscious. Remember, when you're unconscious, that's a life-threatening condition. All of this is a life-threatening condition, but the unconscious patient, you waive the consent because who is going to sign the consent for that? It's an emergency. We waive the consent for emergency procedure. Okay? So AICD, what is AICD? AICD is automatic implanted cardioverter device. So automatic implanted cardioverter device. So you have your own defibrillator or cardioverter inside your body. Okay? It's like a pacemaker. So remember, what is the purpose of pacemaker? For tachycardia or for bradycardia? Who uses pacemaker? Tachycardia or bradycardia? Brady. So therefore, there is a pacemaker for tachycardia, and we call that AICD. Okay, so that's an implanted cardioverter device that is applicable to your patient with VTAC. So every time you have a severe tachycardia because of ventricular tachycardia, it will cause cardiac arrest. It will automatically strike you a shock, and you feel the pinch inside in your heart. Then it will correct the problem. You don't need to have a cardioversion anymore. Okay, so you have a tachycardia, it automatically shock you, and then you're okay. You'll still survive, hopefully for 10 to 20 years. Why not, right? So those are things there to remember in your NCLEX exam for your ECGs. Okay, so let's take a look before we discuss our bradycardia. Let's take a look all our ECG strips which you have there. So which one is ventricular? Which one is atrial rhythm? I'll put the number 1 and the number 2. Which one is atrial? Which one is ventricular? One is ventricular. All right. Number 2 is atrial. That's our letter A's right there. So what type of rhythm is this? Regular, irregular, sawtooth? Irregular. What is the meaning? What is the other term of irregular in our NCLEX, in our ECG? Letter F. Fibrillation. So then, how do you call this rhythm here? Ventricular fibrillation. How do you call the rhythm on number 2? Atrial fibrillation. Look at your middle part right there. They are not the same. Look at that rhythm. They are not similar to each other. They're irregulars. Okay? So by looking at the picture itself, you say, oh my, I know that ventricular, and they are not the same rhythm, so it's irregular. That's a fibrillation. Now you have atrial, they're not the same rhythm, then they are irregular type fibrillation. Are you getting that picture? At least in the picture, you can notice already. You don't need to analyze it anymore. The only thing that you analyze is, okay, fibrillation. I know what will be to look for, what medication would be, right? Let's go to the next strips. We have our number 1 and number 2. Okay. So are they atrial or ventricular? Atrial. They're all atrial, obviously. Okay. So what is the strips on number 1 versus number 2? Which one is irregular? Which one is different from regular to irregular? Which one is tachycardia? Which one is flutter? One is a sawtooth. That's a flutter. That's your sawtooth. Right? Are you getting the sawtooth versus fibrillation? Totally different, right? And look at your normal rhythm. These are normal rhythm, but they are near to each other. That's why they become tachycardia. When it is wide, means far. Wide is far, means bradycardia. Narrowed is fast, means tachycardia.
Number 2 is atrial tachycardia.
Atrial tachycardia. So when it is normal rhythm and it's narrowed, it's only tachycardia. Okay? So that's how you see it. But let's go to the next strips. My God, number 1, I don't want to ask you a question about that. Okay, so number 2, what is number 2? Is it atrial or ventricular? Ventricular, but they are letter B's in similar rhythm. So they are ventricular tachycardia. When it is normal rhythm and they are near to each other, they are tachycardia. And they are letter B, so therefore they are considered to be ventricular tachycardia. So when you see a picture right now, you can tell to yourself what it is. You know what medications you can give based on your drug of choice. You know which one has clot. You know which one to be given with heparin, which one to be given with maintenance dose for Pradaxa or Xarelto. Which one will undergo cardioversion? Those are conscious versus unconscious to be undergoing for defibrillation. All right? So that's how simple it is supposed to be to understand it. But if you want a specialization of ECG, that's another fee, right? That's an ECG class. But that's how it is supposed to be. Why? When you are working in the hospital, you will see the result in the strips anyway. When the doctor called you, Kim, tell me what's the result in the ECG. Just read it. It's right here. It will tell you what's the result, right? You don't need to, hold on, doctor, let me analyze it. You don't need to analyze, just read it, right? And it's not hard in working in the hospital because you have telemetry tech. You have people that watch the monitor for the heart rhythm, and they will just call you, Kim, can you go to your patients first because it's a straight line, right? Can you check the patient? There's an AFib, prepare for heparin, you know? Or maybe Kim or Nick, your patient is having PVC. It's a 7. It might go down to 6. It might be, if it's 6 now, it might go up to 7, which is dangerous. So check the oxygen level of your patient now, and maybe labs, because there's only 2 reasons for PVC: potassium low and oxygen low, right? I think that's not really hard. When you know it, you got it. When you know it, it's easy to work in the hospital. You are not the nurse that keeps walking from end to end. So what happened to you? I don't know what to do. My doctor is asking me questions I cannot answer. Don't forget, in the hospital, you have your charge nurse. So why not talk to your charge nurse and let them talk to the doctor? Because you cannot understand what they're talking about. It takes 3 months for you to understand the doctor's way of talking. There is Vietnamese, there is Indian, there is Middle Eastern, and their English is totally different from ours. And when they talk, it's different intonation, and you cannot understand what he is saying. And if you tell him, can you spell it out for me, doctor? Or you spell it out to yourself. Why you're asking me? You don't understand what I'm talking about? Do you speak English? Right? The doctors are the one asking you, do you speak English? Where did you graduate? Right? So tell them from China.
So yeah, so there's a lot of challenges in the hospital, but it started from here, you learn it and you go there. The only thing that you need to master will be how to communicate with your doctors because you know it already, right? So the only thing that for you now, understanding this, pass the board and work, you're ready, isn't it? Okay, so hopefully you got that one. So this is our PVC, premature ventricular contraction. So what do we have in our premature ventricular? We said bigymy, we said trigymy, and we said quadrymy. Okay, remember when you say bigymy, there's one normal, one abnormal. When you say trigymy, we have one abnormal, two normals, and then we have our quadrymy, two normals, and then two abnormals. So where is our normal? This is our normal right there. That's our normal. Okay, and which one is our abnormal? That one. So one normal and then one abnormal written. Are you getting that in the picture? And I think that's very obvious, okay, when you are in your NCLEX exam. So you count how many PVCs that? 1, 2, 3, 4, 5, 6, 7. Lidocaine or observe? Lidocaine. Because you can only observe when it is 6 and below. All right? When it is 7, it will cause cardiac arrest in your patient. So prepare for your lidocaine. But otherwise, if there is no lidocaine in your NCLEX exam, says check for oxygenation. Of course, you have to do that. That's part of your assessment, right? So let's go to trigymy. One abnormal, okay, and two normals right there. And then followed by one abnormal, then two normals. Followed by one abnormal, then two normals. Then abnormal, then normal. Okay? So that's what you're going to remember right there. So how many PVCs do we have in circles? 1, 2, 3, 4. Do we need lidocaine or do we just have to observe our patient? Just observe. Okay? Let's go to our quadrymy, 4. So what do we have? We have two normals. Okay, so we have our normals right here and then we have our abnormal here. Okay, we have two normals and we have two abnormals. So if you count how many abnormals do we have? 1, 2, 3, 4, 5, 6, 7. So we need to prepare our lidocaine. Otherwise, we need to check our oxygen and potassium level of the patient. Okay, are you getting that one now? Hopefully, please make sure it retains in your brain because tomorrow is another day. All right, when you are busy again for another thing, you forget what you learned. So that's why continue listening or watching the video or go back to your notes and then answer questions on those topics. Okay? So those are our tachycardia. So we're only on the tachycardia part. Okay, so therefore, if we give lidocaine, amiodarone, beta blocker, what are we looking for to observe? Increase urine output. All right. So let's go back to our ECG picture again in our summary here. Okay. So let's talk about bradycardia. So we are now done with tachy. Do you have any questions on tachycardia? Oh, Nick, question? No? Any questions for tachy? You're okay?
For the defib unconscious, you still give heparin before you defib as well?
No, we have to go for our, well, it's not possible for our AFib to have unconscious because they don't go for tachycardia. So the ones that really go for unconscious is our straight line. All right, so it's our straight line. But if it is an AFib, before you shock, make sure you have heparin. Okay, only for AFib, not for any other ECG in your tachycardia. Okay, so let's talk about bradycardia.
Bradycardia have many meanings, and it is stated as wide heart rhythms. So when you see the rhythm, they are apart from each other, we call that Brady. Because when it is too near, it's narrow, that means tachy. So when the heart rhythms, like the atrials, and they are too far from each other, then therefore it becomes a bradycardia. Okay? Depends on what type of widening distances do they have. So it can be first AV block, second AV block, and then of course third AV block. So whenever you see the word in your NCLEX exam, heart block, AV block, winky back, and move beats, all those words are used for bradycardia. Okay? But if you want to make sure to understand when there is heart block or AV block, any block is a bradycardia in the heart. Okay? The only block that could make you tachycardia if you are being hit by a hollow block. Right? But every block is a bradycardia in your heart. Okay? So take note, there are three rhythms in your patient's bradycardia. When it is first AV block, their heart rhythm is below 60. Do you treat this one with digoxin? Yes or no? No, because it's already brady. Digoxin is not intended for bradycardia. Digoxin makes your heart rate goes down. Okay? That's why every time you are going to give digoxin, hold it when it is below 60. Make sure you have the word below 60. Because 60 is okay. Below 60 is not okay. Okay? So if you have a choice in your NCLEX exam, it says 62, below 61, and then 60. Which one is the correct answer? 62, below 61, and then 60. Which one you hold the digoxin? Below 61. Because the clue is the below. It is going down. All right? So see, when we add some words, you are confused already. 60. We don't say that it's below. It's just 60. Okay? So always remember, not only digoxin is the one that we hold below 60. All of these medications for anti-tachycardia, we hold it when the heart rate is below 60. All anti-tachycardia medications should be held below 60. Okay, so let's talk about Synthroid. What is the action of Synthroid? Thyroid gland, right? So you have Synthroid for hypo or hyperthyroidism? Hypo. All right. So then let's talk about what's the other medication for hyperthyroidism? PTU. All right, PTU, propylthiouracil. You're familiar with that? So between Synthroid and PTU, which one will lower the heart rate? Remember, you're focusing in your patients with hyperthyroidism and hypothyroidism. Is which one is your focus? It will be the heart, the pulse rate, right? So when you have hyperthyroidism, what happens to your heart rate? Tachy. So when you give PTU, when are you gonna hold it? Below 60. So we are connecting other medications to this. All right. So we are not only thinking of below 60, that's always digoxin. There's a lot of them. Any medication that will lower the heart rate, hold it below 60. Okay. All right. So let's go to your AV block. So first AV block, your heart rate is below 60. Do not give any anti-tachycardia medication because it will cause more brady. Second AV block is now below 50. So your heart rhythm is below 50 already. And that's more dangerous for your patient. And then third AV block is below 40. The question is, who is candidate for pacemaker? Who will be your candidate for pacemaker? The third AV block. All right.
So the rest will be medications, and we use our medications. We call them anti-bradycardia medication. And these are our anti-bradycardia medication, right? We call that IDEA medication. So this medication will cause tachycardia. Hold it when the heart rate is above 100. Okay? So isoproterenol is a bronchodilator. It's a very dangerous medication for children. And then dopamine, dobutamine, epinephrine, and atropine will cause tachycardia. But remember, epinephrine is given to asystole because there is no heart rate, right? It's flat. That's why we want to wake up the heart. So it will increase the heart rhythm. Once the heart rhythm goes up 100 and above, you hold it. Okay? So how do you know all these medications are working with your patients? Effectively increased urine output. Okay? So if there is no increased urine output, then absence of chest pain is correct answer, right? Because whether it is tachy or brady, they might end up with chest pain. So then, if there is a tendency for a patient to go over below 40, then therefore pacemaker will be inserted in the patient's chest. All right. So it's either pacemaker or electrical pacer. They are the same. All right. So then the doctor can have a surgical procedure to insert the pacemaker or electrical pacer. It's battery operated for 10 years. And whenever there is manifestations of malfunctions, the first malfunctions manifestation is hiccups or single twos. And then it might become that your heart rate is lower. How come my heart rate is brady again, right? So maybe the pacemaker or the electrical pacer malfunctions already. Okay? Remember, you have to check your heart rate or pulse rate every single day, 60 seconds, full 60 seconds if you are taking any medications for the heart. Because you want to make sure it's not below 60, it's not above 100. Okay? So before you give medications, the same thing, you have to check. If it is beta and calcium channel blockers, they will lower your blood pressure and your heart rate. So you have two parameters to check. If the medication only lowers the heart rate or increases the heart rate, there's only one parameter, and that will be your heart rate or pulse rate. Okay? So we teach them how to check their pulse rate. That includes our patient with hyper and hypothyroidism, because their medication will decrease or increase the heart rate. Okay? So that's our ECG. But remember, this is just an update, a shortcut method for you to understand it, and you will still have a good discussions in your discussions with Walter. Okay? So any questions? So here is the presentation of your normal to abnormal rhythms in bradycardia. So take note, what is normal rhythm is like this, right? That's the normal rhythm of the heart. And then first degree, it becomes wider. They're far from each other, and then too wide and so wide. They're too far. Then you will know already. So bradycardia is easy to see in your test because the atrials are far from each other. Okay? But going back to other things, so remember winky back, the blocks are words in your NCLEX exam to remember that they are bradycardia. Bobits, all right, second degree or first degree, they are the same. But then another one that could be in your NCLEX exam is Adam-Stokes disease. That's still also considered to be bradycardia. So there's a lot of meaning. I just want you to learn all those terminologies because you don't want to skip anything to learn before taking the test because you don't know what will come up. Well, the better that you learn it now, even if the simplest word you will see in the word NCLEX is there, but they are very useful when you are starting to work. Okay? So that's our updates for our NCLEX exam.